welcome to today's hot topic webinar for volunteers, volunteer managers and coordinators across South Australia to discuss a really important topic about dementia. And we're really excited to have a guest speaker talking to us about this topic today. I'll just start this session by acknowledging the traditional owners of the lands of wherever we are today and pay respects to elders past, present and emerging. Recognise anyone in this webinar or watching it later with First Nations heritage. And also to acknowledge that sad news and sorry business happens on the lands and seas around us as well, all the time. And it takes a community to look after each other. And the Aboriginal population has a huge amount of experience and knowledge in this area, and we're keen to learn from them. My name's Shyla. I'm the CEO of Palliative Care South Australia, and we run the Palliative Care Volunteering SA project in collaboration with Volunteering SA and NT, Northern Volunteering SA and Southern Volunteering SA. And this project's part of the Palliative Care Connect project, which supports people to navigate across the palliative care system in South Australia. So that's enough, a bit of a background to us. Today's session, we're delighted to have Mel Ridings here today, who is the team leader for client services. And we'll walk you through questions around what's available for you around dementia supports and what this all means. We will do a little bit of a Q&A opportunity at the end. So if you have any questions, feel free to pop them in the chat or in the Q&A area. If we run out of time, please still put them in there and we can link up and email you the responses as well. We will make this session available on a recording after as well, so it will be available to watch at different times. So enough from me, over to you, Mel. Thank you so much.
Thank you. Thanks very much for that introduction. And thank you all for having me today. So we'll get started. There is a lot of slides, but I'll promise to keep on track so that we've got some time for questions at the end. So firstly, I just wanted to start by talking about what is dementia. I mean, that's a big loaded question and we could spend the whole half an hour just talking about that. But very briefly, dementia is an umbrella term to describe a set of symptoms caused by brain disease or a disease of the brain. So if you think about it like another diagnosis that nobody wants, cancer, you have cancer as the umbrella term, and then you have cancer of the bowel, you have breast cancer, brain cancer, etc. Dementia is the same as that. In dementia is the umbrella term, and then you have different types of dementia that affect different parts of the brain. So some typical signs of dementia are gradual changes in thinking that get in the way of a person doing everyday things. No two people are affected in exactly the same way, even if they have the same type of dementia, and it is not a normal part of aging. So a few quick facts and stats about dementia. Every 3 seconds, someone in the world develops dementia. That doesn't mean that every 3 seconds somebody's diagnosed, but somebody will develop dementia. In 2025, there is an estimated 4,333,300 people living with dementia in Australia. And again, that's people being diagnosed. In 2025, there is also an estimated 29,000 people with younger onset dementia in Australia. So that's somebody that's been diagnosed under the age of 65. And by 2054, it is estimated that 812,500 people will have developed dementia in Australia. So the biggest risk factor for developing dementia is age. Of course, the other option is not great either. But typically, 1 in 4 people over the age of 80 will develop dementia. And of course, that risk continues to grow the older we get. So there are over 150 types of dementia. I am not going to name them all, mainly because I couldn't. I don't know anybody that could name all 150, but the 4 most common types are Alzheimer's disease, vascular dementia, Lewy body disease, and frontotemporal dementia. So Alzheimer's disease is the most common and usually makes up for about 50 to 70% of people diagnosed with dementia. And the first signs of Alzheimer's disease are short-term memory loss. Vascular dementia is another common that overlaps often with Alzheimer's disease, but vascular dementia can happen anywhere in the brain, and that's due to lack of blood or oxygen to the brain. Lewy body disease is very similar to Parkinson's disease. They have a lot of crossover, and frontotemporal dementia affects the front part of the brain and also the sides as well. So how a healthy brain works, I'll run through this part very quickly because again, we could spend 30 minutes just talking about this, but the frontal lobes are in charge of planning, organising and decision-making, starting and stopping actions, regulating social behaviour, working memory, speech and insight. So somebody diagnosed with frontotemporal dementia, for example, may display a lot of these symptoms. The temporal lobes are in charge of hearing and understanding language. And the brain stem, which meets up with the rest of the body, the spine, controls involuntary functions like breathing, heart rate, blood pressure, sleeping and coordination, all the things that we don't control. The parietal lobes, so more towards the top and middle of the brain, is for sensory processing, attention, reading and writing, calculation and spatial orientation. The occipital lobe is for processing visual input. The limbic region for forming and processing emotions and memories, and that's also at the back, sort of sitting with the occipital lobe. And lastly, the hippocampus, which memories are stored all over the brain, but the process is coordinated in the hippocampus. It's a bit like everybody's library. And in Alzheimer's disease, again, the most common type of dementia, the damage in the brain will start in that hippocampus. So just quickly, because I'm sure in your volunteering roles, whether you're working with somebody who might have a diagnosis of dementia or supporting a client that may, there are many things that can mimic dementia. Depression and anxiety, for one, sensory problems, metabolic disorders like diabetes, if somebody was having a hyper or hypo, so low or high, malnutrition, physical trauma, pain or infection, and sometimes those are undiagnosed pain or infection, fatigue, delirium, some medications, dehydration, constipation, and grief. So a lot of things with very similar signs and symptoms that you may come across in your roles. And something to consider when you're working with people with dementia is the person's experience of dementia. So a lot of these factors come in to play. So someone's personality, they may have always been a bit aloof. That's not going to change with the diagnosis of dementia. Most likely they'll just become more so. The social context of their life history, you know, where they were born, where they grew up, their schooling level, all that sort of thing. The type of dementia, because as I mentioned a few slides ago, depending on where the damage is in the brain, will affect different functions or different cognition. And of course, their general health as well. So in your volunteering roles, you may have come across some changed behaviours or changed responses, is the term we prefer to use, to somebody you're supporting. So it could be, as I mentioned a few slides ago, those typical things that may be mimicking dementia. However, it could be as a result of dementia and some of those possible changed behaviours. So these may include, these are sort of the most common we would see, repetitive questioning and or conversations, which I'm sure some people could relate to, may be caused by a person's inability to remember what they've said or done. If the explanation doesn't help, sometimes distraction may help, or some open-ended questioning that doesn't rely on the memory. A loss of initiative or withdrawal, apathy from a situation, they may need encouragement or a prompt to participate. Agitation might be restless energy, getting up and down, not able to settle, not able to concentrate on a task they used to enjoy. Wandering or purposeful walking. It may look like wandering to us, but for the person with the diagnosis, they have a purpose. They're walking for something, for some reason. And evening restlessness, or if the person's living in residential care, you'll quite often hear the term sundowning. Some other possible changed behaviours could be signs of depression or anxiety. Again, they mimic very much so. Making accusations, disinhibited behaviour. Again, this depends on where the damage is in the brain to how common these might be. declining support from others, e.g. declining to bathe or get dressed or go out. Collecting items, and this is quite commonly happens with food. It might be the person has simply forgotten that they've bought the food, or they're holding on to objects from past experiences, for example. And the last one is aggression. So that might be physical, such as hitting out, or verbal, e.g. using abusive language. So why does this happen? Why do people have changed responses? I'm sure you could understand that if there were changes in the brain and things were stopping your regular cognition, it would be quite frightening. So it's usually out of fear. And of course, we'd look at this, what we call the caused model. So working through this when there is a changed behaviour using this model. So cause stands for, the C is for communication. So are you communicating well with the person with the diagnosis for them to understand and it's clear? Have a look at the activity. So is there something about what's going on that they're engaged in, or how has it been explained that might be challenging for the person with dementia? The U for unmet need, or are they unwell? So they might be unwell, they might be in pain, they might want to have a shower because they're cold, for example. It's fitting for today, I think. And that they can't focus on anything else until that need is met. What's their story? So that's what the S is about. So what's their history? Could their behaviour be explained by something from their past or a different aspect? The environment. So what's happening around the person with dementia that could be contributing, or does the environment need to be more dementia friendly? And the last one, and it is purposely put in a small lowercase d, is there something about the type of dementia, or has that impacted the person's ability? So an example I use quite often with the caused model when I was working in residential care is we had a dear English woman who would sob the entire time she sat on the shower chair, the whole way through the shower until she was out and dressed. And it's not uncommon, and a lot of people don't like to be that exposed in front of somebody, and you can understand that feeling. But what was actually going on for this person when we talked to them in a different setting, not when we were setting them up for the shower, was that growing up in England, her family did not have a lot of money, and they would bathe once a week in a metal tub in their backyard in north of England, with no hot water. So when she was in her room and her clothes were taken off, sat on the shower chair before she went into the shower, of course she was cold and uncomfortable, and all those feelings came back. And she was quite traumatized by that whole situation. And of course, not even the warm shower in there really helped, because she had to get back out. The window was open and she was cold again, and those feelings came flushing back. So it can be a lot of reasons that people react to what we did. So if we try to think of the caused model, hopefully we can narrow down some of those reasons. Of course, another big factor, not only for the person with dementia, is change responses, but there might be changes in how they communicate, but it also means that we need to change how we communicate. So if you think about ways that we do communicate, our body language, our tone and pitch of voice, words and writing, behaviour, images, clothing and appearance, and objects, they all contribute to how we communicate with each other every day. For somebody diagnosed with dementia, often the words or the writing lose some of their meaning. They're not picking up on all the words, and they will respond more to the body language and the tone of pitch of voice and what they're viewing. So, for example, if I came to you today, not that you can see my feet, but if I was in Ugg boots and a ripped jumper and, my hair was everywhere, I think you would not take what I'm saying so seriously as looking a bit more presentable, and that's your clothing and appearance. And of course, open body language and that sort of thing. So just something to consider. So communication changes for the person with a diagnosis. A person with dementia may experience changes in their communication skills, and at a time when they need them most, really. Other people can help the person with dementia maintain their independence and quality of life by adjusting their communication. Very important, again, in the roles that you're all doing. So some examples of changing, and these are similar to some of the examples we talked about earlier, but repeating things, again, is a really big one, repeating stories, words, questions. That can be that can be because of reduced short-term memory loss, which is likely to the brain sort of being on a train basically and can't getting off. They may struggle to begin a conversation. They're happy to have a conversation, but actually starting that is hard. Difficulty finding words. It's a bit like roadworks basically, which we're all familiar with in Adelaide. But when there is a blockage in the brain can't use the normal path that it would to find something, to recall something, and that might be a word. Instead, it's got to find a different track. So it's got to reroute, it's got to detour and find another pathway in the brain to get the information or the word that it wants. So you might find for the people that you're supporting that the word does come back to them, or what they wanted to talk about does come back to them, but it takes them time because the brain's finding that new route in the brain. Difficulty following complex conversations. It may just be too much too soon. Reduced concentration and lapses in memory. Some other examples of changes is difficulties expressing needs or feelings, finding writing or reading quite challenging, and again that can be because the words have lost meaning. Difficulty following multi-step requests, disinhibition, making comments out of turn or in the wrong social context, and confabulation. So what might appear as making things up, but again, that's the brain trying to make sense of the situation or of a memory. So this slide, what does it take to make a cup of tea or coffee? I want you to have a think while I'm talking through about how many steps you might think there is to make a cup of tea. Most people usually predict around 8 to 10, and it's actually about 18 to 20. So before you even get to the physical act, you've got to decide that you want a cup of tea. That's what you want. Walk into the kitchen. What do you see? The cupboard doors. Where do I keep the tea bags? Where do I keep the kettle, the spoons, the sugar, the cups? You've got to find it. Find the kettle, find the sink, fill it up, open the kettle lid, fill up the tap, turn on the tap. Then you've got to turn off the tap, remove the kettle from under the tap, close the lid of the kettle, plug it in, turn it on, wait for it to boil, and you haven't even got your cup out yet. So that's what I was talking about with too many steps. Saying to somebody, let's make a cup of tea might be too much. The first step could be, let's fill the kettle. And you go from there, breaking those steps down. So to help with some communication, we talk a lot about the 6 S's. So the first is slow. Not what I'm doing today, but look directly at a person when communicating. Be patient and give the person time to respond. And we would usually say about a 5-second suggestion. That should be enough time for it to go through the brain. And what you can say to somebody is, do you want time or do you want help if they seem to be struggling? Keep it simple. So one idea at a time, reduce distractions and pay attention to body language. Be specific in what you're saying. So paraphrase what you've heard, confirm with them what they've told you, and write down important points for you both to look back on after. Show, so use hand gestures and facial expressions. A smile goes a long way. I mean, even for people without a diagnosis of dementia. Point, demonstrate, or use cues, and consider symbolic language as well. Number 5 is still. So stay still while you're talking with the person. Don't, walk around the kitchen trying to do 3 things while you're having the conversation with them, and try not to interrupt or argue. And the last one, as mentioned before, smile. So a smile and humor can sometimes be better than words. It just relaxes everybody. And use touch to catch and keep a person's attention. So we're there. I'm aware of the time. That was very brief, but how Dementia Australia can help. So some of our services, we have individual and family support with dementia support specialists. We also have counselling. Again, that's individual or as a family or a couple. Our National Dementia Helpline is 24 hours a day, 7 days a week, and you can reach that on 1800 100 500, but it's on all of our literature and websites as well. We have support groups for carers. We have a lot of information and resources, education sessions, both online and in person, in a range of places throughout South Australia. So that's not just for Metro. And we also have advocacy, and this is a national presentation, but here in South Australia, we also have the Nightingale program, which is a palliative care nursing program as well. And that's also in Metro and regional too. Our Dementia Australia Library, our librarians are fantastic, and they will find you anything you could possibly want. So everything is free from that. You can get physical books, audio books, digital, research papers, DVDs, topic guides. They will find it for you. So there's a few ways you can get in touch with the library, such as through our website, through the email at library@dementia.org.au, and also again through our National Dementia Helpline. So just a few key messages from me. Dementia is not a normal part of aging. As I said, it affects a lot of people, especially older people. However, it is not a normal part of aging. There are many, many types, and everybody is infected in a different way, sometimes in a different hour, different minute. It progresses over time. Dementia affects everybody differently. Support is available, and it is still possible for the person and their support people to live well. And I'll open it up to any questions. I'm just going to go through to the last slide, which has got our National Dementia Helpline phone number on it. So I'll leave that up for everybody to have a look at as well. But thank you very much.
Mel, firstly, just congratulations for squeezing so much fantastic, really user-friendly information in such a short period. I learned a lot as well from that, so thank you.
Oh, great.
It's amazing. There is one question there in the chat, which I'll read to you, that says, can you please address the issue of people with dementia and voluntary assisted dying? Or at what point can they and their loved ones decide to assist them to die if they have chosen that via an advanced care directive, or if they have no quality of life as decided by their carer or loved one?
That's a big question. Unfortunately, dementia is not covered under voluntary assisted dying at the moment. I'm sure most of you are aware, but the main criteria for VAD or voluntary assisted dying is that you need several doctors or specialists to sign off that the person has 6 months or less to live. And through some of that information in the presentation, I'm sure you can understand that there is no timeline for a diagnosis with dementia. There's no way to say that the person will have even declined significantly, let alone be at a palliative phase in 6 months. So there's no two doctors, unfortunately, that would agree to sign off on that. Dementia Australia is doing a lot of work in this space to hopefully change that. But of course, each state is different in legislation as well for their voluntary assisted dying, where Dementia Australia are looking at it a bit more nationally. So it's not over, I suppose, but unfortunately, at the moment, it's not an option for people with a diagnosis of dementia.
Yeah, thank you for that. And I'll just put a link in the chat. There is a fantastic website called the End of Life Law Australia. So that gives an overview about voluntary assisted dying and supports in other jurisdictions as well, just if people are interested in that area. But as you said, it's not at this time, it's around competency also at the time when they take the voluntary assisted dying. So yeah. I think the big thing, like you mentioned, is about getting the supports available for people when and where they need it and accessing it that way. I guess just to wrap up, seeing the time, and if there's any other questions, please feel free to pop something in the chat, anyone. This will be made available online and as a video that people can watch after as well. Mel, what would be your one take home, you think, for people today? What's something that they can all think about or hope that they learn to sort of action from today?
I think the most important thing is to understand that everybody is different with a diagnosis of dementia. I mean, everybody's different without one. A diagnosis of dementia makes no difference, and that people just need understanding. You know, they need that support, they need that communication. And, you know, particularly from, again, if it's somebody that everybody here is working with today or a client that you're supporting, taking time, giving them time, to respond, to articulate, and never making a judgment, I suppose.
Beautifully said, and that's so valuable for all of us, isn't it, in this space? We all know people that are affected by this and will be in the future. So it's really important that we have that knowledge and we have that space and, yeah, value this information that you've given us. I can already see some great comments in the chat about how valuable this was. So thank you, Mel. We make these short and sharp because we know how busy life is for everyone.
Yes.
But you've covered a huge amount, and the number is there. Dementia Australia and the Nightingale program, particularly in SA, does an amazing job. We're very lucky in South Australia for this, but I think the big message also for everyone is you're not alone. Any questions that you've got, reach out, because there's a lot of supports, there's a lot of information and a lot of people willing to help and be there for you. So thank you very much, Mel, and your team for what you do. And also thank you to all the volunteers and the volunteer coordinators that have jumped on today. We really hope this is useful for you all, and we look forward to continuing to collaborate and open up topics of conversation that you're asking for. So we've got a hot topic tomorrow on grief and bereavement, and we look forward to people joining us there or watching this later online. Thank you again, Mel, and have a beautiful day, everyone.
Thank you. Bye for now.